Hi, my name is Matt Gubens. I'm a professor of medicine at UCSF. I'm the medical director of thoracic medical oncology. I am very happy to discuss some of the ASCO 2023 important lung cancer abstracts that were presented at the meeting. We'll start with EGFR mutated non-small cell lung cancer because that got the biggest billing. We'll start with early stage disease. I'll talk about Adara. Adara is, to my knowledge, the only time a presenter has been able to present two plenaries because we've had two big updates from this trial. This, of course, is a phase 3 study for stage 1B to 3A resected EGFR non-small cell lung cancer, the canonical mutations of exon 19 deletion and L858R. And they randomized 682 patients to either osimertinib 80 milligrams for 3 years or placebo for 3 years. Adjuvant chemo wasn't required, though could be given at the discretion of the investigator and the patient, but the osimertinib had to start within 10 weeks of surgery without therapy and within 26 weeks with. The primary endpoint was disease-free survival in the stage 2 to 3A patients. And this is already reported at an ASCO plenary a couple of years back. And this showed a very impressive hazard ratio of 0.27. And as you see, a marked improvement in the median DFS of 66 months versus 28 months. But one of the key secondary endpoints, and something we've been waiting for a while, is overall survival. And so this is what Dr. Herbst was able to present this year at the ASCO plenary. And what he showed us was the hazard ratio was 0.49 in the stage 2 to 3A patients. And so at a 5-year landmark, 85 versus 73% were alive at that point. There was more data presented for earlier stage disease. Interestingly, the FDA label covers all stages, doesn't make reference, just says resected disease, though there's an ongoing 1A study. So even when you look at the stage 1B patients, still there was a very favorable hazard ratio here, 0.44, with an overall survival rate of 94 versus 88% at 5 years. So this was exciting. We were waiting for this, perhaps not a surprise, but important to see the disease-free survival translate into overall survival benefit as well. It was already FDA approved, so I think it was a part of many of our practices, but this was just more data to corroborate the clinical benefit. This was very compelling. There remains a lot of discussion, though, about crossover. This was an international trial. The status of first-line osimertinib for metastatic disease was evolving. And so they did point out in the presentation that the crossover to EGFR TKI was pretty robust in the placebo arm at a point of progression, but only 43% of patients got to osimertinib, which we really know is a superior drug at that point. So it's not optimal, but I think it does reflect the reality of how osimertinib was coming into practice during the conduct of this trial. So while this is kind of a viable strategy going forward, one of the big questions is going to be when patients do progress, because there are patients on that Kaplan-Meier curve that are going to have progression. What does resistance look like at that point? Are they going to have the C797S? What does that look like? What do their survival chances look like with the next line of therapy? That really needs to be seen with longer term follow-up. I think an also important question is also, can we figure out who are the 1As and 1Bs that are at higher risk, or even the later stage who are at less risk if they have contraindications to osimertinib? Can MRD help to risk stratify? And I know that some of those correlative data are coming from Dr. Herbst and his group. And then, as I mentioned, there are upcoming trials looking at data here. One of them to look at the use of neoadjuvant and adjuvant osimertinib, the NeoAdura trial, and then to look at that specifically that stage 1A group to look at Adara 2. Again, they're in the FDA label, but they weren't included on the Adara study. And I think also importantly, as we kind of start borrowing from the experience of CLL and breast, is 3 years the optimal length of time? If we're not curing patients, is there still benefit to ongoing suppression? And so at least the first pass of that is going to be this phase 2 target trial looking at a 5-year instead of a 3-year duration. Also presented was actually from our group. It was a phase 2 trial looking at the use of neoadjuvant osimertinib in surgically resectable EGFR non-small cell lung cancer. Our colleague Dr. Rado presented that on the behalf of Dr. Blakely's group. We had a phase 2 study that had stage 1 to 3A resectable disease, had to have the canonical EGFR mutations, exon 19 deletion and L858R. And the idea for these 27 patients was to offer osimertinib for 1 to 2 months prior to surgery. The primary endpoint was major pathologic response, but of course, looking at how many CRs we are, kind of to look at, since we're looking at all these neoadjuvant trials, what complete response looks like. And then kind of important for the practical aspects of these patients, do we downstage their nodal disease? And then ultimately we'll be looking at 5-year DFS and OS and looking at surgical complications and the unresectability rate. And what we found was that there was a major pathologic response rate of only 15%, and there were no complete responses after 1 to 2 months. There was a lot of downstaging. Out of 9 patients who had N-positive disease, 44% were downstage, and the median DFS is robust. We had good R0 surgical resection rate, 89%, and only 3 out of the 27 had to be kind of taken off the surgical route for concurrent chemoradiation, 1 for progression, and there were no surgical complications. So the take-home messages were that there's really no pathologic complete response with this neoadjuvant approach. There was some major pathologic response, but did not meet the primary endpoint. So this is not as robust as some of the chemo immunotherapy neoadjuvant approaches we're increasingly taking. But that said, it's a safe approach. There's a good R0 surgical resection rate, and there is some lymph node downstaging, so that can be clinically useful. And of course, this approach is going to be looked at more rigorously and in a broader population in the phase 3 neo-ADARA trial, where the patients will get the neoadjuvant and the adjuvant osimertinib together. So building on ADARA and adding the neoadjuvant component. So onward to EGFR mutated non-small cell lung cancer in the first-line metastatic setting. One of the presented abstracts looked at the use of chemo with EGFR TKI. And of course, this is a road we've been down in several phase 3 trials. The novel aspect of this one was that it was quote unquote inserted chemotherapy. So the idea here was to give the first 56 days of TKI alone, then give 3 cycles of cisplatin pemetrexed, and then go back to the TKI. They started with gefitinib. That was the standard of care when the trial started, and then they revised it over to osimertinib after the FLAURA results really changed our first-line standard of care. Their primary endpoint was overall survival. And what they showed us, so they randomized 501 patients, about 2/3 of them gefitinib, and then the rest of them to osimertinib. And there really wasn't an overall survival benefit for either gefitinib or osimertinib, though of course the osimertinib data are not quite as mature. For PFS, there was a little bit of a directionality toward benefit from the inserted chemotherapy approach, but for neither of these drugs was it. For gefitinib, it was positive with a p-value of 0.0015, not for osimertinib as yet. So it's kind of another in the set of trials where TKI plus chemo in the EGFR space offered PFS benefit, but as yet really no overall survival benefit. So again, not likely to change practice. We don't really want to intensify unless there's a reason to, and that's where I'm really excited about the trial out of MSK that's looking at the use of early MRD positivity to choose patients then to add chemotherapy. So if you start with osimertinib and you still have observable disease after a certain juncture point, you're randomized to adding chemo to the TKI or leaving the TKI alone. So Dr. Yu's study, I think, will be really important. This is, I think, this kind of smart precision medicine in this kind of MRD setting. Onward to the metastatic disease second line and beyond. So, of course, this was, I think, a really answering an important question that we've had in the community for a long time. We've been giving the Keynote 189 regimens and other chemo IO to a lot of patients as a first line. But when our EGFR mutated patients wind up progressing on osimertinib, is there a role for chemo immunotherapy? So this was a phase 3. The Keynote 789 was a phase 3 well-designed study, and it took the patients with canonical EGFR mutations either after first-line osimertinib failure, or if they started with a first or second generation, they have to have also had osimertinib if T790M was the mechanism of resistance. If it wasn't, they could go straight on the study. And the patients were randomized 1-to-1 to either carboplatin or cisplatin with pemetrexed and pembrolizumab with pembro and pema maintenance, or just the chemotherapy. And the primary endpoints were dual, PFS, and overall survival. So a question we've really been asking ourselves over the years and was only incompletely looked at by studies like Empower 150. And so what we saw was that the PFS at interval analysis 2 showed that the median progression-free survival was really minimally different. This p-value is low, but it doesn't meet the statistical significance boundary at this interval analysis. Similarly, with overall survival, at the final analysis, you just see more than a month difference at the median, and again, a non-statistically significant difference. If you break it down a little bit, we're not sure how PD-L1 status plays in. There's maybe a hint that the PD-L1 positive patients maybe had a little more robust benefit, but again, a subgroup. But overall response rate, really not difference between the two arms. So again, in these patients, as fit and young and robust as their immune systems are, we're finding that this mechanism of action really is not helpful, either in the single agent, we learned years ago, really low single-digit response rates, but even in the hopefully synergistic setting with chemo, we really didn't see meaningful improvement. So really still an unclear role for current immunotherapies in the EGFR population. Another study was looking at following osimertinib with going backwards, going to a second generation afatinib and adding chemotherapy. This is maybe kind of a parallel to the IMPRESS study of Tony Mock many years ago, where patients who were progressing on first or second generation TKI stayed on the TKI potentially with chemotherapy. This was just a phase 2 single arm study of 71 patients. And again, patients went on this lower dose of afatinib with the standard carbopemetrexed and then pemetrexed maintenance. And the primary endpoint was progression-free survival at 6 months. And what we saw was that the 6-month PFS rate was 57%, the median PFS was 8.2 months, the overall response rate was 49%, and the toxicity seemed manageable. These do compare pretty favorably to standard chemo alone. If you look back at the Keynote 789 data I just presented, this is a better response rate nominally. The median PFS is longer than that kind of 5-month range we expect, but I'd always have a little caution interpreting a phase 2 trial. But there might be a there. It just probably needs randomized confirmation. In my practice, I would still only continue the TKI if the patient had stable brain mets and I'm using the chemotherapy to address progression systemically. So moving on to HER2 mutated non-small cell lung cancer, not that much action at ASCO this year. Of course, we've been using trastuzumab deruxtecan for second line and beyond per the FDA label and eagerly awaiting the first line trial. There was an interesting paper presented by Liu et al. That looked at the kind of the ctDNA attributes of patients at their center. Basically looked at the MSK population, found 64 patients who were found to have HER2 mutations and who had prospective ctDNA. And it turns out about just shy of 80% of them had that observable HER2 mutation prior to initial therapy. And those patients tended to have shorter overall survival. So maybe that suggests if you have enough tumor to find on the circulating tumor DNA, you just may have higher burden of disease. It should be noted that most patients in this early cohort actually didn't see ADCs for their HER2 mutated disease. This is kind of an older patient population. Not many of them saw either trastuzumab deruxtecan or even just trastuzumab. So I think we have to see this through, but it's kind of an interesting first look at some potential ctDNA correlates that might be useful for our patients going forward. So kind of moving on to immunotherapy in the non-small cell lung cancer space, I'll start with the resectable setting, where there's been so much action in the last few years with the approval recently of neoadjuvant nivolumab plus chemotherapy. Well, a really big phase 3 trial was presented at ASCO and simultaneously published in the New England Journal. This was Keynote 671 presented by Heather Wakely out of Stanford. And this looked at the use of perioperative chemo with or without pembrolizumab in early stage non-small cell lung cancer. The details of these trials are important. We want to make sure that we're kind of comparing apples to apples. This trial enrolled patients with stage 2, 3A, and 3B disease, as long as the 3B was by virtue of N2 and not higher. And they, of course, could have had no prior therapy. They were randomized 1-to-1 to chemo, a cisplatin combo with either gemcitabine or pemetrexed, with or without pembrolizumab for 4 cycles neoadjuvantly. And then, importantly, different from the nivolumab data set, also randomized that also had patients get a year of adjuvant pembrolizumab as well. So that earns it the perioperative moniker. So a more extensive amount of treatment. The primary endpoints were event-free survival and overall survival, and the key secondary endpoints did include the pathologic responses. And what she presented, first of all, kind of looking at the patient population, this was about 70% well balanced in terms of stage 3 entering this patient population. They were majority non squamous disease. The breakdown was pretty even among the PDL strata, so about a third, a third, a third high. Positive and negative. And EGFR and ALK were allowed. These are patients sometimes we would maybe select against, I think, in terms of a lot of our judgment, but a small number of patients on both arms had these alterations. The R0 resection rate, excellent. These are patients who got through surgery. This was higher in the patients who got the pembrolizumab by a numerical amount there. And the event-free survival was mature, and that's why they're presenting it. The hazard ratio was 0.58, highly statistically significant. And looking at the landmarks at 12 months, it was 73 versus 60%. Overall survival was immature, hazard ratio 0.74, though hints at maybe some benefit along those lines. And then I think another important thing as we compare these trials going forward is what kind of pathologic CR rate are we seeing? So the pathologic complete response rate was 18% in the pembro arm and 4% in the chemo-only arm, very comparable to the recent nivolumab data. So very important trial, wouldn't be surprised if this led to an FDA approval. The question remains, what is the additive benefit of that year of adjuvant immunotherapy? That was not baked into the nivolumab data set. And so it probably requires longer term follow-up of these survival curves to see if there's a persistent benefit and in whom, because certainly a year of immunotherapy is going to confer additional cost and toxicity. And of course, we don't expect a head-to-head trial anytime soon. So really important data set, but the second in what will be a march of other phase 3 trials emerging, and we'll have to be comparing subgroups along the way. Also, an interesting study presented, albeit a smaller one, was looking at not neoadjuvant chemoimmunotherapy, but neoadjuvant chemoradiation and immunotherapy, followed by surgery and followed by adjuvant immunotherapy, in this case, durvalumab. This was just a phase 1b study and including 30 patients. These were clinical stage 3, including N2 disease and patients who were resectable. They got weekly carbopaclitaxel along with durvalumab and along with radiation to 45 gray. Then went to surgery and then had their year of durvalumab. And the primary objective was safety and tolerability. And again, not randomized. It's a small data set. These patients, you see here, largely farmer tobacco users. This was a majority squamous cell population and well balanced between PD-L1 levels. Out of the 27 out of the 30 patients who went to resection, all were R0. Only 3 didn't, 2 due to toxicity, 1 due to patient refusal. And when you compare the pathologic complete response rate, it's really been in the high teens, kind of 20 range for our neoadjuvant immunotherapy plus chemo. This one was 41%. So again, a small patient population, but if we can select our patients and do it in a safe way, is there a role for more intensive neoadjuvant therapy? Maybe radiation still plays a role here, especially in this higher risk stage 3 setting. But of course, would be very important to see in a broader population what surgical outcomes look like, what long-term survival looks like. It's always fun at ASCO to see what the emerging trials are, the studies in progress. And in this space, we're seeing a lot of these phase 3 trials mature that look at neoadjuvant chemo plus immunotherapy. Well, there is kind of an interest in adding some of the novel immunotherapies. So one of the interesting studies in progress that was highlighted was NeoCOAST-2. So these were patients who, along with chemo and durvalumab, would also get an additional immunotherapy, either oleclumab, which is a CD73 antibody, or monalizumab, an NKG2A antibody. Or, interestingly, as we think about the role of PD-L1 and CTLA4, volrustomig with chemo, which is a bispecific PD-1 and CTLA-4 bispecific antibody. And so this is really interesting. We'll kind of see what these look like in terms of path CR and safety. Of course, whenever we're adding agents, we're always mindful in the neoadjuvant setting about not giving people enough toxicity. They don't get to their curative surgery. So every incremental addition, while we may look for more efficacy and look at the interesting correlative science, we want to make sure people actually get to surgery. So it'll be important to follow this.
So volrustomig, I haven't heard that one before, but I maybe need to start practicing it. Sounds super interesting. Can you explain a little? I've never heard of it, but it sounds pretty wild. What exactly, a PD-1 and CTLA-4 bispecific? Wow.
Yeah, at least a couple of companies are going down this path of combining PD-1 and CTLA-4 with their bispecific platforms. And at least preclinically, there's some evidence that co-locating them might actually be more effective and less toxic. This particular sponsor points to, at least again in these preclinical assays, more T-cell proliferation than if you just give independent PD-1 or PD-L1 along with CTLA-4 antibodies. So kind of interesting, and so far safety data look pretty compelling. But there are at least a few bispecifics in this space that we'll have to see how they pan out. The nivolumab plus ipilimumab trial that was actually part of the Nivo chemo neoadjuvant trial didn't pan out. So we'll have to see how this works in this particular disease setting. But there's at least some rationale or hypothesis that bispecific may be the preferred way to deliver those two inhibitory approaches.
But just to be clear, the two sort of ends are both going after PD-1 and CTLA-4. There's nothing else. There's no immune CD3 or anything else. Wow.
No.
Wow.
Yeah. Yeah.
I mean,
kind of interesting. Yeah, they're trying all the permutations, right? But I think, but again, it's interesting. It's so fascinating as companies have become more savvy about their platforms. How do you design these designer antibodies? And I think there are some opportunities here, and we've got to just see how they work clinically.
Yeah, we just did a webinar on bispecifics and lymphoma, and that was like, I was holding my breath the whole time, man. It was amazing.
Yeah.
The last thing I said was, we need more of this in solid tumors. Well, maybe
so
this
true.
is it.
Well, and as we've talked about many times, we've got such an important patient population. Sometimes we're leading the way, but sometimes we're following. We're learning about how to use adjuvant, neoadjuvant approaches, where our breast colleagues have been doing this for a long time. But yeah, how can we use some of these novel technologies to deliver our drugs and hit our targets better? Really fascinating area.
Although you've got amivantamab, which really is an unusual and I think unique bispecific.
And potentially has a few roles across the EGFR spectrum, sure. Right? Their foot in the door was EGFR exon 20, but I think we're going to see some more mature data about its use in the EGFR refractory population, in the MET amplified or overexpressed or mutated situations. So I think that's a fascinating compound that we're going to see legs for.
The thing that I find interesting about amivantamab is, most of the bispecifics, which of course we hear about in heme, are, one arm of the bispecific is going after immune cells, but amivantamab, they're both going after the tumor, which is, you don't see too many bispecifics out there like that, which is interesting.
Right.
And this thing here, this is really wild. I mean, this is totally wild.
Yeah.
All right, please continue.
All right, kind of going on to immunotherapy in the early stage unresectable disease. Here's the space where Pacific made its trail and has become the standard of care, where we give the chemoradiation followed by the year of durvalumab in that stage 3 unresectable setting. Pacific hasn't stopped with Pacific. There's a whole portfolio, and one of the important studies to follow is Pacific 9 that was, again, shown as a study in progress. This is going to be a phase 3 huge study, 999 patients, same as the Pacific population, unresectable stage 3, who have already had their chemoradiation and don't show progression. And they're going to get randomized 1:1:1 to durvalumab plus placebo, the Pacific kind of standard of care, versus adding to durvalumab either oleclumab, the CD73 antibody that reduces extracellular adenosine production, or monalizumab, the NKG2A antibody that keeps NKG2A from binding HLA-E, thus reducing the inhibition of natural killer and CD8 positive T cells. So both with kind of interesting data from the phase 2 COAST trial and basically putting where their money where their mouth is and seeing in a phase 3 registrational trial if this will bear fruit. The primary endpoint will be PFS and, of course, secondarily looking at overall survival.
What do we know about tolerability, autoimmune issues, et cetera, when you add these two agents?
Yeah, the COAST study showed that these were, aside from kind of showing a hint of efficacy beyond durvalumab alone, these didn't introduce too much more in the way of autoimmune. I don't have the numbers at the ready, but these were safe enough that it felt prudent to proceed with a phase 3 approach.
Interesting. Please continue.
Also in the Pacific portfolio is Pacific 8. This is a phase 3 study, again, unresectable stage 3 disease, also with no progression after definitive platinum-based chemoradiation, and notably patients who have PD-L1 greater than or equal to 1%. These are patients we randomized 1-to-1 to durvalumab with placebo versus durvalumab plus donvanalumab, which is a TIGIT antibody. The primary endpoint will be PFS in patients with the high PD-L1, 50% or higher, and then secondarily kind of taking the broader swath PFS in everyone 1% or higher, looking at other efficacy measures as well. And, you know, we've seen kind of a mixed story so far in TIGIT in lung, but there's at least a hint of benefit in some of the settings. The ARC-7 did show benefit in the high PD-L1 patients, which is what led to this bet here in the PD-L1 high patients in the stage 3 setting. And then we're going to move to immunotherapy in the metastatic setting. And actually, the first study I'll present is not an immunotherapy study per se. It's kind of one of the first maturing data sets for a whole set of trials we're going to be seeing in the next few years of these ADCs. So datopotamab deruxtecan plus pembrolizumab with or without platinum chemo. So this is still the phase 1b data that's kind of driving the phase 3 trials I'll mention in a minute. This is the first time they're evaluating Dato-DXd with pembro and with or without chemo in non-small cell lung cancer. So they have 6 cohorts. They're looking at the ADC with pembro and carbo, or pembro and cisplatin, some of them priorly given treatment before, some of them treatment naive. And again, as a phase 1b study looking at safety and tolerability, but really trying to drive the efficacy as well as other data that will inform the phase 3 data to come. And what they presented as an update at this ASCO, first of all, the doublet, where they just got the Dato-DXd with pembro. There were 64 patients, a little more than half of them seeing this as their first line of therapy, and basically saw a pretty respectable response rate here. 20% in the PD-L1 50% or higher, 44% in 1 to 49, 36% in the non-expressors. The confirmed and pending overall response rate is at 38%, but 50% in the first line. So these are very respectable numbers. In the triplet setting where you're getting the ADC, the immunotherapy, and the chemotherapy, these were 75% of these 72 patients were first line, 25% of them had prior immunotherapy line. And what we saw was an overall response rate of 49% and 57% in the first line. In terms of safety, I always look at discontinuation rate, about 23, 28%, not dissimilar to our doublets in other settings. But I think that especially as lung cancer docs who haven't been using these compounds as much, some of the mucositis that we don't usually see in our lung cancer drugs, we did see a fair bit of that, kind of 58, 43%, depending on triplet versus doublet. ILD is seen at some rate. And of course, the ocular toxicity, especially dry eye. But I know the eyes always get us a little more cautious, especially when there's a dearth of ophthalmologists to help us out. So the early take-home messages, these are early but encouraging data, but really it's trying to whet our appetite for phase 3 trials that are already accruing. And the 2 big ones we're going to be looking out for in lung, TROPION-Lung07 is in the PD-L1 less than 50% setting, where you're getting the Dato-DXd plus pembro and platinum versus Dato-DXd plus pembro alone versus just the standard pembro pemetrexed platinum. And then separately, for the high PD-L1 expressors, there's the phase 3 TROPION-Lung08, which is looking at Dato-DXd plus Pembro versus Pembro alone. So we'll see if there is an incremental benefit over the standard of care, whether that's the Keynote-24 regimen or the Keynote-189 regimen, and we'll see what the toxicities look like. I think this is a different kind of ADC than what we were talking about before, with a payload here that makes it just a directed chemo, but certainly with some of the chemo side effects and the magnitude of those toxicities are really going to affect how these drugs do in the clinic and how well they compete with our current standard first line therapy. We pulled this abstract as well. This is kind of an interesting look. I think that almost all of our trials enroll patients with good performance status in the 0 to 1 range. This study purposefully set out to only accrue performance status 2 patients who had PD-L1 positivity and give them immunotherapy alone. It was a phase 2 single-arm multi-center trial with 48 patients with advanced non-small cell lung cancer. They had to be unsuitable for chemo according to the PI. And because there was some early toxicity in patients who had bad dyspnea, they later added as an amendment, patients had to have less than grade 3 dyspnea to be enrolled. They had to have EGFR, ALK, and ROS1 wild type disease. The primary endpoint was overall survival at 6 months. And what they showed was a very reasonable overall response rate, 6 months, 60%. If you excluded those early patients with bad dyspnea, probably heralding either really bad burden of disease or potentially bad COPD, then the OS 6 month went up to 67%, median OS of 8.5 months, and a response rate of 17%. I think in practical terms, we already kind of know this. We know immunotherapy is easier to give. So I think even though we're not enthusiastic in healthy patients about using immunotherapy alone in the PD-L1 to 49% range, when you start talking about PS2, that being a very heterogeneous group, I think we're pretty comfortable with that already. This gives us some data in that regard. That said, we don't have much data here about why patients for PS2, what made them chemo ineligible. It'd be nice to get that kind of granularity. I'd also point out that the PD-L1 cutoff for durvalumab is actually 25%, not 1% as it is with pembrolizumab. So it definitely kind of speaks to the need for more research in PS2 patients as well as the geriatric population. I think these kind of other populations who are historically excluded but come to our clinics, we need to have more data about how to use these and to use these intelligently.
Do you know anything more about the sort of dyspnea thing, like how many patients it occurred in? Was this, immune pneumonitis on top of COPD, or what was going on there?
It's just a poster presentation, so not much granularity there that I recall. So I think that's a fair question, because that's, especially in the lung cancer population, that's going to be a pretty heterogeneous spread of why people are dyspneic, either at baseline, which is what they excluded later on, versus those that developed it. I don't think there was undue pneumonitis in this kind of PS2 population, but I think there could have been disease burden and COPD issues.
I mean, this comes up with, TDXD that can cause pneumonitis maybe more frequently. And, one of the things that I think about in contrast to other cancers, because as you say, so many patients with lung cancers have pulmonary comorbidities, is what do you do clinically? So let's just talk about IOs, because that's used much more commonly. Obviously, if you got a patient on oxygen from COPD, you don't really get too excited about getting pneumonitis on top of it, yet, maybe it's the only chance they really have for a good outcome. How much pulmonary dysfunction do you have to have for you not to want to use a checkpoint inhibitor?
I think the first piece I look at is the extent of radiographic pneumonitis. When I start seeing multi-lobar disease in anybody, that's giving me a fair bit of pause. So that's a point where at least I'd hold and think about steroids depending on the dyspnea and the oxygen level. Yeah.
I'm not talking about how you manage pneumonitis. What I'm talking about is, will you start a checkpoint inhibitor in somebody who already has, pulmonary dysfunction?
Gotcha. In a patient who has pre-existing pulmonary dysfunction from COPD, say kind of, really, oxygen dependence or very limited, 6-minute walk or some such, I use these drugs without reservation, but I'm just more mindful to symptoms. I'm doing more patient counseling to say, I really need to hear if that cough is worse. I need to hear if your already bad dyspnea is looking worse. And, when you're walking up those stairs and you're stopping twice instead of once, I need to know that. So it's more preemptive counseling, but I don't withhold these drugs even in patients who are oxygen dependent.
Yeah, that makes a lot of sense. Please continue.
Another interesting study in progress here is, in the second line after failure on immunotherapy with or without chemo, is how do we improve on our old standard of docetaxel, which has been remarkably tenacious as kind of beating almost all comers. So this is kind of one of the many approaches here. This is ceralasertib plus durvalumab versus docetaxel after patients have already seen immunotherapy. So this is taking EGFR ALK wild type patients who are second or third line if they got the immunotherapy and the chemo in sequence. And it's adding the ceralasertib, which is an ATR inhibitor, which is thought to lead to inability to repair DNA damage, making the cancer cells more susceptible to the durvalumab you're also giving them simultaneously. The primary endpoint will be overall survival. And this is just one example of the many trials that are saying, let's pit X plus immunotherapy against docetaxel in the second and third line. It's remarkable how many dozens of trials have gone down this space, and we still don't have a victor over docetaxel. We had our first kind of hint with the SWOG trial, which showed last year, which is being parlayed into the phase 3 Pragmatica trial, but we still haven't seen a phase 3 winner over docetaxel, or I should say docetaxel plus ramucirumab, since the advent of immunotherapy. So it's weak sauce, but we don't beat it very well. So hopefully one of these approaches, maybe with better agents or maybe better patient selection, might get us there. One of the most provocative abstracts presented at this ASCO was the oral presentation on tumor treatment fields. So the LUNAR study was a phase 3 study looking at tumor treating fields with standard of care after platinum-based therapies. So just a word, because this is a technology, a different modality than any thoracic oncologist has really been using. The idea here, straight from their literature, is that these electric fields exert physical forces on electrically charged components in the dividing cancer cells, leading to an antimitotic effect without directly, drug or direct intervention. Downstream effects, they speculate, include some stuff that may well leverage the use of immunotherapy with tumor treating fields, like cell stress-induced immunogenic cell death, triggering systemic anti-tumor immune response. In the chest, it's delivered by a wearable medical device and 2 pairs of arrays, so kind of front and back, left and right. You use them for 18 hours a day or more, and you wear a backpack with the power supply. It's already FDA approved for glioblastoma and for malignant pleural mesothelioma. I'd say the mesothelioma community hasn't been especially enthusiastic in the uptake. I don't know any of my colleagues who are using this on a routine basis. I mean, it's discussed because it's on the table, but I haven't prescribed it myself. And notably, that was a single-arm study, so the data weren't so compelling. We were all looking forward to this randomized controlled trial. So what Dr. Leal presented, this LUNAR trial, it enrolled metastatic non-small cell lung cancer patients with progression on or after platinum-based therapy. And that's an important distinction I'll come back to, not necessarily immunotherapy. Performance status 0 to 2. There were 276 patients randomized 1-to-1 to either tumor treating fields therapy with standard of care or standard of care alone. The investigator's choice of either immunotherapy or docetaxel. And there was stratification by region, by the standard of care treatment, and by histology. Primary endpoint, overall survival. And with key secondary endpoints looking at the folks who are getting immunotherapy with the tumor treating fields versus docetaxel with the tumor treating fields. So again, even before I show the results, we already see one issue with this trial. And of course, this is just a trial that's been open for a while and the field changed under their feet. These days, no one would get a platinum therapy alone as a first-line regimen. So to have second-line immunotherapy the way we gave when we were first seeing the nivolumabs and pembrolizumabs come to market is really not how we use these drugs now. That said, it was a positive study. Overall survival in the intent to treat population was 13.2 versus 9.9 months, hazard ratio 0.74, and clearly statistically significant with a p-value of 0.035. The benefit appeared to be more robust in the patients who were getting immune checkpoint inhibitors, 18.5 versus 10.8 months, whereas in the docetaxel treated patients who presumably had already seen chemo and immunotherapy, here the hazard ratio was only 0.81 and was not statistically significant. Also notable, the PFS in both populations, the treatment arm and the control arm, were both on the low side at 4.8 versus 4.1 months. One of the interesting points they made reference to that I think we'll have to see in future presentations are this is a direct effect. It's applying these electrical fields across the thorax, not against metastatic disease, say in the liver, the brain, or elsewhere. So it'll be important as we look at this technology, this modality over time, is when there is progression, how much of that is in field, directly hit by these electrical fields, how much of it is out of field, because that would be an interesting thing to see if we saw really good control in the thorax, but lost control elsewhere. But they did not really report that out in this data set. This is a safe approach. Really, the main side effect of the tumor treating fields is the dermatitis, and it's usually very low grade, grade 1 or 2. I think as a hirsute person, it'd be more frustrating for me because you have to shave your chest. But in terms of discontinuation rate, there was a higher discontinuation rate in the treatment arm, 36%. It's not dangerous, but I think there's more the nuisance and time factor. So in terms of take-home messages, this trial is a phase 3 trial. That's what we ask. It's an overall survival trial. It was safe, though, with a time factor and inconvenience factor. But I think what still gives some of us pause is it did have this outdated study design. Really, patients are getting immunotherapy first line. So this either should have been with chemo IO, or it should have been with first line IO, or it should have been with docetaxel in a pure second line setting. If you dig into the data, it's also kind of one of the questions raised by the discussant, which I thought was a fair one, is there's not really an a priori reason we would think that the overall survival benefit would be more in the ICI treated patients compared to the docetaxel treated patients. I guess maybe you'd have to invoke some synergy with the immunotherapy. But again, I think this is a data set that's a first step. It got our attention. It's not FDA approved yet in this broad patient population, so we'll have to see how the FDA handles it, though notably the pathway for devices is less rigorous than that for drugs. But I think a lot of folks in the audience said, this is interesting, would really like to see some of the upcoming data. I know the sponsor's working on this to look at a more contemporary patient population.
Do you know if there are any ongoing phase 3 trials right now with this treatment modality?
I'm not sure. My understanding is they are being planned. I think they acknowledge this criticism of the data. So I'm just not sure if it's been activated yet or if it is about to be activated, but I know at least one of the approaches will be chemo immunotherapy plus or minus the tumor treating fields.
Also, do you know that did they require that all the tumor be within the chest to go in the trial?
They did not. So I think that's a fascinating way. I hope they eventually show these data about infield versus outfield progression status, right? I mean, I think back to the small cell world where we did consolidative radiation in extensive stage small cell lung cancer. That was an approach for immunotherapy. And, obviously local control is really important for that very aggressive disease. But the question was always, you're radiating this, what about all the brain, liver, bone mets that are outside the thorax? So I think we really have to be looking at those data fine points as they emerge.
So, I mean, I guess you could justify it if it's not that toxic, which I'm not sure about, just based on sort of tumor reduction, bulk reduction. But maybe, could you envision any kind of abscopal effect where somehow it's releasing neoantigens that the immune therapy would scoop up or something?
That's their speculation. When they look at their kind of preclinical data, they do think that there is not just a local, but maybe a more abscopal or distant anti-tumor immune response. Again, I'm not sure this was the data set to prove that, but it's definitely part of their preclinical work and something they'll be looking at in future trials. It'd be hard to give tumor treating fields across the whole body, right? But it's been useful in the GBMs where they are so focused, that really don't metastasize outside their very aggressive setting in the brain. I think it'll be interesting to see in the lung cancer where metastatic disease really is the expectation outside stage 4A disease, to see it elsewhere in the body. How effective are we in the long run against those patients' tumors?
Incidentally, before you go on, let me just ask you about one other thing related to immunotherapy. Because I've been hearing about this. I heard it first in melanoma and then in pancreatic cancer. Maybe it's other areas that I didn't know about, which is the idea of RNA vaccines that have neoantigens. I don't know if you've heard about this. There's this study in melanoma where they used an mRNA vaccine that was tumor informed. It was only phase 2, but it looked very interesting. And then in pancreatic, there's another one that sounds kind of similar. It really sounds pretty cool. Are they trying anything like that in lung cancer?
There are some phase ones in non-small cell lung cancer that we haven't been a part of, but I think it's pretty exciting boutique kind of precision-oriented medicine, isn't it? It's especially following the enthusiasm for that approach in terms of the COVID vaccine development. How great that we can now leverage that against specific cancer targets. I think it's fascinating, but nothing that's kind of emerged, I think, past phase 1 to my knowledge as yet. But non-small cell lung cancer is in the hunt.
Cool. All right, let's talk about small cell.
Yeah, bringing it home in small cell lung cancer, nothing too revelatory this year at ASCO. This was just a poster that was of a little bit of interest in terms of thinking about how to use, the Empower 133 regimen or the Caspian regimen. In this case, how do we think about using first-line chemo durvalumab? How can we do our best in terms of shared decision-making with patients? Caspian, as other big phase 3 studies, do collect patient-reported outcomes. And so this group, I thought, did an interesting job of trying to correlate the health-related quality of life data in a multivariate model to see if they could use the factors to predict PFS and OS. And what they found was, I think, not counterintuitive. I think what they found was that patients who had better global health status at the outset, patients who had better physical role, emotional, and social functioning, patients who had less fatigue, less nausea, vomiting, less pain, less appetite loss, less constipation, and fewer financial difficulties, by the way, tended to have better progression-free survival. And these all might be proxy of disease burden as well as kind of social supports. The only kind of one counterintuitive thing when you do all this model building, you always have to scratch your head at one of the variables. And they did point out that a better diarrhea score, so less diarrhea, predicted worse overall survival. So I got to scratch my head on that one. But again, not revelatory, but I think it could be something that informs us saying, hey, your performance status is X, but what are the factors that build into that? Does that affect how we might approach our first line therapy in this really morbid disease? Also interesting, really actually a pair of studies. This was the one that was pulled by the team. The Trident study, durvalumab plus olaparib as maintenance therapy in extensive stage small cell lung cancer. Kind of some interest in the use over the years in PARP inhibitor, and can we find a patient population in whom this might be helpful? So this took patients who already had their 4 cycles of chemoimmunotherapy, in this case durvalumab plus platinum etoposide, and then they added to the maintenance durvalumab twice daily olaparib until progressive disease. Primary endpoint was PFS at 1 year, variety of other efficacy measures, but exploratory wise, and why it becomes important, is can we figure out in whom this might be beneficial, particularly the role of SLFN11. What they found was PFS at 1 year, 19%, median PFS at 5.8 months, an overall response rate of 73%. And, generally well tolerated. This is a short duration treatment, as we kind of know from small cell lung cancer. And so in the broad population, not that exciting. But there were some outliers in their data set, which really suggests the need for that forthcoming biomarker analysis. But I think it's important to draw attention to Dr. Karim's study. She presented SWOG S1929 at ASCO this year, basically did that biomarker selection from the get-go, chose the SLFN11 patients, and just gave them talazoparib in addition to maintenance atezo after chemo atezo, and did find a positive study with PFS of 4.2 versus 2.8 months. And again, not revolutionary, but kind of getting us closer to the point where we might think about subsets of small cell lung cancer and do a better job of precision medicine in that really morbid disease. But SLEFN11, one of those important biomarkers, so much work about subtyping small cell, and maybe we'll eventually get to a point where beyond the histology, we actually are choosing based on the genotype of the tumor. Another interesting study was looking at ablative radiation in addition to durvalumab in extensive stage small cell lung cancer. This was a study in progress, but as I mentioned before, we got very used to the idea after finishing chemotherapy before the immunotherapy days of giving consolidative chest radiation. There was overall survival benefit at 2 years with that approach, even for patients with more broadly metastatic disease. We're not quite sure. There's ongoing studies to look at that in the chemo IO era. But this got a little more aggressive and said, let's take these 49 patients in a phase 2 trial, have at least one lesion that meets criteria for SBRT. They'll get their 4 cycles and their maintenance durvalumab as a standard of care, but we will plan to do early SBRT to 1 to 4 extracranial sites at the cycle 2 setting. So earlier than that old consolidative radiotherapy, and a little more permissive in terms of organs involved, as long as they were SBRT eligible. The primary endpoint will be PFS. The secondary endpoint will be overall survival. I think this is very compelling. This is very akin to some of the work being done in non-small cell lung cancer too. I'm thinking of the trials, especially in EGFR, where we kind of get our patient to maximum response and then try to do consolidative SBRT or surgery, some kind of local therapy to try to improve at least PFS and maybe OS, is the North Star trial out of MD Anderson. So I like seeing this approach in small cell lung cancer as well. I've been looking forward to these results.